certains pays et nous allons l'examiner pour voir s'il existe des traitements de substitution comme dans d'autres addictions. La deuxième partie de la réunion va se consacrer à d'autres problématiques, la e-Santé et une conférence sur la récupération, quelque chose de très important qui devient très important, surtout avec la schizophrénie. Nous devons, en plus d'éviter que les gens y boivent, il faut permettre aux gens de reprendre leur vie et avoir une existence de bonne qualité. Et maintenant, on parle beaucoup de récupération, mais on va en parler plus tard. Donc, commençons.
Me? Can we have the first presentation? No, it's Roberta. Roberta is starting with Baclofène, and basically look at two issues, that is efficacy and safety of Baclofène, both in withdrawal treatment and in the maintenance of abstinence treatment. Roberta is known for some of a very, very important and insightful reviews and working with the Cochrane Institute. And so I'm sure you get a very high level understanding of this issue. Roberta.
Thank you. I can understand. Oh, okay. I suppose.
Just start.
Okay. Thank you. Okay. Thank you. Good afternoon, everyone, and thank you, Wim and Julien, for inviting me to this interesting meeting. And my name is Roberta AGABIO, and my topic is the evaluation of the efficacy and safety of Baclofène in the treatment of alcohol withdrawal syndrome and in the treatment of alcohol use disorder. I'm speaking slowly because a lady closing the box asked me to be very slow. So, next one, please. Oh no, I need to do it by myself. Okay, so let's start with the first issue. What about the efficacy of Baclofène in the treatment of alcohol withdrawal syndrome? I look at the latest, could you explain me where you have to press for the pointing? I guess, yeah. Okay, thank you. So, can you see?
I hope you don't see it very well because the thing is so bright.
Okay, isn't that? Put it. Okay, maybe. Oh, thank you. Thank you so much. But I don't know if. So let's. Okay. Yes. So I just looked for the more recent Cochrane systematic review, the one published by Dr. Liu and Dr. Wang in 2019, and this systematic review evaluated as the main outcome the severity of alcohol withdrawal syndrome assessed using the Clinical Institute Withdrawal Assessment for Alcohol Scale, and they included only 4 randomized clinical trials with less than 200 participants, and unfortunately, none of these studies evaluated the efficacy of Baclofène in preventing alcohol withdrawal complications like seizures or delirium. And as you can see, one study compared the baclofen to placebo, 2 studies baclofen to diazepam, and the last one baclofen to chlordiazepoxide. And the authors did not find any differences between baclofen and placebo. But the problem was the quality of the evidence that was very low. And for people who are not so confident with these labels used by systematic review, very low means that the authors have very little confidence in the estimated effect. And even for the safety, the quality was very low. So the conclusion were that there was insufficient data and very low quality evidence. However, looking at the single RCTs, we can see that for the first study, the one by Giovanni Addolorato and colleague, data on the severity of alcohol withdrawal syndrome were provided as a graph and were not included in the meta-analysis. And for the last one, Lyon et al., there was no difference between baclofen and placebo in the severity of alcohol withdrawal syndrome, but there were a significant difference between baclofen and placebo in the need of diazepam. So people who received placebo needed more diazepam than people who received baclofen. So according to the latest randomized clinical trials, those not included in the systematic review, one study, the first one, compared 2 different doses of baclofen to placebo and evaluated the rate of patients in need of diazepam and the amount of diazepam required by participants. And they found that baclofen was effective compared to placebo because patients treated with placebo required a higher amount of diazepam, and also the rate of patients who required diazepam was higher. And the second one compared the baclofen to lorazepam, and they did not find differences between baclofen and lorazepam. And the author also concluded that both medications were well tolerated. And the last one actually did not include the patients with alcohol use disorder and a real alcohol withdrawal syndrome, because these patients were patients who had an unhealthy alcohol use. And they received also mechanical ventilation. And the authors were aimed at evaluating if baclofen could reduce the number of events related to agitation. And they found that baclofen significantly decreased the number of these events. So maybe the Cochrane systematic review needs to be updated to include the results of the studies. And what about the Cagliari expert consensus group? In 2018, a group of international experts in the field of the treatment of alcohol use disorder using baclofen, during an international conference, the GABA-B receptor conference in Cagliari, my town in Italy, decided to combine their expertise to provide concise and well-balanced information regarding the use of baclofen in the treatment of alcohol use disorder. And regarding the use of baclofen for the treatment of alcohol withdrawal syndrome, this group of experts reported that baclofen should not be used instead of benzodiazepines in the treatment of alcohol withdrawal syndrome, because there is no evidence of its efficacy in preventing the complication of alcohol withdrawal syndrome. sorry, the same group of experts, the year later, published a review in Frontiers in Psychiatry, and we replied that to date, unfortunately, no study has evaluated the efficacy of baclofen. So these are the conclusions of this group, and I would say are my conclusion on the use of baclofen for the treatment of alcohol withdrawal syndrome. But I would like to add that there is a need, and I asked for an update of this systematic review by the Cochrane Drug and Alcohol Group. And what about the use of baclofen in the treatment of alcohol use disorder? As I have already introduced our international Cagliari expert consensus group, these are the sentences regarding the use of baclofen for the treatment of alcohol use disorder. At the time we published this consensus in Lancet Psychiatry in 2018, baclofen was not approved yet in France. Now it's available in France, but for all the other countries, it is used as an off-label medication. And we decided to underline that it should be used as a second-line pharmacotherapy for patients who do not respond to other approved medications like naltrexone or acamprosate. But it may be considered a first-line medication for those patients who have contraindication for the use of the other medications. For instance, patients with severe liver disease. And we also added that the dose should be personalized according to their response, safety, and tolerability. And the same group also evaluated the systematic review and meta-analysis published to date. And we observed that the different systematic reviews included different studies and also evaluated different outcomes. So we look at the single studies, the primary studies, the studies included in these systematic reviews. And as you can see, to date, we have 16 studies, and these studies largely vary because they used different doses coming from 10 milligrams per 3 times a day to almost 90 milligrams 3 times a day. And they also varied in the severity of alcohol use disorder if we look at the number of drinks per drinking days, ranging from 0, because they were detoxified, obviously, but maybe 7 to 18, or the duration of the treatment from 4 to 48 weeks. But looking just here at this column on the efficacy, this study, approximately half of the studies, found that baclofen significantly reduced alcohol use in patients with alcohol use disorder. And the other half did not find any difference between baclofen and placebo. So there are also other issues other than the doses, the duration, the severity. For instance, other mental disorders, gender differences, or other issues. But the question is the same. If you were a physician, would you prescribe baclofen to your patients, considering that now it is approved in France, but not in other countries? And also considering the inconsistent evidence coming from different studies and systematic reviews. And also considering this history of Olivier Amaizan, maybe all of you know his story, a French physician with alcohol use disorder who treated his own alcohol use disorder with high doses of baclofen also wrote a book that became a bestseller. And now there are several patients that ask for this treatment, but on the other hand, we also know that baclofen is related to side effects. So what could we do? Looking at the latest systematic review. The first one is a systematic review published by Cochrane. The second one was a systematic review in which we evaluated the effect of anxiety of patients, and the last one published by Dr. I don't remember the name, sorry, but published this year on patients with liver disease. So, regarding the Cochrane systematic review, we included only patients with alcohol use disorder and study that used baclofen and compared the baclofen to placebo or other medications approved for the treatment of alcohol use disorder. And we also evaluated as the outcomes the relapse, the rate of abstinent days, the rate of heavy drinking days, the number of drinks per drinking days, and as safety outcomes, the number of participants with at least one adverse event. I have to speak slowly, I don't. And the number of dropouts and the number of dropouts due to adverse events. And in this systematic review, we also evaluated the role of potential influencing factors. Alcohol use at baseline, dividing participants according to their alcohol use at the beginning of the study. If they were already detoxified by at least 3 days, or if they were still drinking at the beginning of the pharmacological treatment. And according to the dose received, so equal or lower than 10 milligrams 3 times a day, or equal or lower to 100 milligrams, or higher than 100 milligrams, and according to the duration, shorter or equal to 12 weeks or longer than 12 weeks. So, we included 17 RCTs and almost 2,000 patients. And most studies compared a single dose of baclofen to placebo, but 5 studies compared the 2 different doses of baclofen to placebo, and 1 study baclofen to placebo and acamprosate or acamprosate and naltrexone. And this is just an explanation of these labels we use. And when we say the evidence is high, that means that we are very confident in the estimated effect. And 2 very low, but we have already seen very low. So this slide shows the results of we found regarding the efficacy outcomes. In red, you can see that baclofen resulted to be effective compared to placebo in reducing the risk of relapse. And we assigned the moderate certainty of evidence. And this result comes from 12 data sets and more than 1,000 participants. We also found that baclofen significantly increased the rate of abstinent days compared to placebo, and the certainty of evidence was high. And this result comes from 16 data sets and more than 1,200 participants. On the other hand, we did not find any difference between baclofen and placebo in the other 2 efficacy outcomes, the rate of heavy drinking days and the number of drinks per drinking days. I should underline that the number of participants were lower compared to the other outcomes. And when we divided the participants according to the different doses or the different duration of treatment, we found that these results were not modified. So these results are the same even when we divided participants according to this potential influencing factor. On the other hand, we found an interesting result. When we divided participants according to their alcohol use at baseline, we found that the efficacy of Baclofène in reducing the risk of relapse were available only for patients who were detoxified and not for patients who were still drinking at the beginning of treatment. We find a similar result looking at the rate of abstinent days. So we found that Baclofène increased the rate of abstinent days only among participants who were detoxified at the beginning of the studies, and not among participants who were still drinking. So this slide shows the results for the safety issues, the number of participants with at least one adverse event, the number of dropouts, and the number of dropouts due to adverse events. We found no differences between Baclofène and placebo, and the certainty of evidence was high for all of them. And we did not find differences dividing participants according to the different doses and the duration of treatment. The only difference we found was that Baclofène resulted to be effective in reducing the risk of dropout using high doses. So when you increase the dose of Baclofène, you may reduce the risk of dropout. On the other hand, looking at the single side effects, we found that according to the sedative effects induced by Baclofène, Baclofène increased the risk of tiredness, dizziness, somnolence, but also dry mouth, headache, paresthesia, and muscle spasms compared to placebo. But we did not find differences in all the other single side effects we evaluated. So, what about anxiety? In 2021, we published a study, a systematic review, in which we aimed to evaluate the role of anxiety in the effects induced by Baclofène. So we could include only those studies that provided both baseline and end of treatment data of alcohol use and anxiety. So we could include only 9 studies. But we found that Baclofène increased the rate of abstinent days. When we divided the participants according to their anxiety levels at baseline, we found that Baclofène was effective only among patients with higher level of anxiety at baseline. And it was not effective among patients with lower level of anxiety at baseline. It was a really very complex work to do because also the scales used by the singular study to evaluate the anxiety were different among the studies and not validated for people with alcohol use disorder, but all of us know that. And so the last one, the systematic review conducted with the patients with severe liver disease. This study could include only 2 randomized controlled trials, and so they concluded that because of the limited number of studies, they could not draw clear conclusion according to the efficacy. And they only describe the adverse events. They could not conduct a meta-analysis. However, they also reported that no study reported a decrease of liver function. So they said that Baclofène was a well-tolerated medication among these patients. So I would like to conclude with the same statement for the alcohol withdrawal syndrome of the Cagliari consensus group. Unfortunately, we do not have evidence for suggesting Baclofène instead of benzodiazepines in the treatment of alcohol withdrawal syndrome. Okay, well, someone normally the reference, the soins is not written by me, I don't know. And we need to update the Cochrane systematic review. According to the treatment of alcohol use disorder, we found that Baclofène is effective in reducing the risk of relapse and increasing the rate of abstinent days. However, these results were consistent if patients were detoxified at the beginning of treatment. And we found no differences in other efficacy outcomes, like the rate of heavy drinking days or the number of drinking days, but it was also well tolerated, increased the risk of adverse events like somnolence, and we should take it in account when we suggest the use of this medication in patients who are still drinking because of the risk of sedative effects due by Baclofène and alcohol. But we should also note that it doesn't not induce liver deterioration. So Baclofène could be useful for some patients, not for all. So we could say that it is a step toward what we call the personalized medicine, considering people with liver disease, anxious people, and people who are detoxified. And so this is my last slide to thank my colleague of the Cagliari Expert Consensus Group. And as you can see, Professor Van den Brink is one of our colleagues, and the people who work with me for the systematic review, including the Cochrane Drug and Alcohol Group. And obviously, thank you for your attention.
Thank you very much. I think we have time for one question. Is there? There's one. Maybe there's more, but.
Thank you. I'm Gavin Bart from University of Minnesota in the United States. We have limited experience with it. We don't use it very often, except in some extreme cases where other medications are not appropriate. One concern we have had is the potential for withdrawal, and most of the safety, withdrawal from the Baclofène itself, and most of the safety analyses have been safety while on Baclofène, and they are more silent about the safety of sudden cessation of Baclofène. Is that something you could address, the potential for withdrawal from Baclofène itself?
Thank you for your question. And yes, Baclofène can induce withdrawal, but when you give Baclofène at high doses for long period. And the cases of withdrawal I read in some case reports come from studies conducted with children that received Baclofène intrathecally administered. And if I'm not wrong, I found only one case report of withdrawal for patients treated for alcohol use disorder, because the doses are not so high. But I don't know if someone has other responses for this topic.
I have so many questions, but I will keep the question for the end of the session. Yeah, it can be very touchy with baclofen because we know that according to the dosage, it can decrease the threshold of epileptic seizure. So the replacement from benzodiazepine to baclofen, I'm not sure there is a clear added value in clinical practice. But we know that in patients treated for long term with high dosage, in our practice we are using high dosage because we are severe patients. When you stop suddenly the treatment, there is a high risk of delirium tremens, alcohol withdrawal syndrome, the same clinic. We have patients who were admitted in the emergency department for other reasons than alcohol, and the doctors from the emergency department stopped suddenly the treatment. Our patient developed a typical alcohol withdrawal syndrome, which is a GABAergic withdrawal syndrome with delirium tremens. So, and risk of epileptic seizure as well. So the treatment, you put again baclofen, or you treat with benzodiazepines. Yeah.
Another small thing, I have not provided how to administer it and stop the treatment, but this is something maybe you know. You need to increase very slowly the dose at the beginning, and at the end you need to decrease very slowly at the end to avoid this risk. But the risk exists.
Thank you. Which, by the way, we now need to do with all psychiatric medications, isn't it? Okay, thank you very much, Roberta. We have to move on for the sake of time, so I think I'm the next speaker. And I'm Wim van den Brink. I'm working, I used to be a professor of addiction and psychiatry at the University of Amsterdam. And can I have the... So I will talk about the efficacy, safety of sodium oxybate in withdrawal and maintenance of abstinence. And there is a certain reason why it has the same title as that of Roberto, because the third speaker is going to talk about issues on substitution treatment. And if you want to do substitution treatment, maybe you want to have both effects on withdrawal and on maintenance of abstinence. So there is a built-in logic in the presentations in that sense. So this is my conflicts of interest. I think the most important is that I was a consultant for DNA Pharma, and of course that is one of the companies that was working with sodium oxybate. This is my program, the content. So I'll start with a short introduction. And not too long. You all know that alcohol dependence is a very serious disease, that most of our treatments are effective, but only to a certain degree. We also know that we need better medications if we really want to make a big influence. There's also some issues on contraindication of some medications, and so far it doesn't seem that there was one drug that was effective both in alcohol withdrawal syndrome and the maintenance of abstinence. And so here is where sodium oxybate might have some influence. This is something about the mechanism of action. We'll be brief about that. You see that sodium oxybate, SMA abbreviated, binds to the GABA-A and the GHB and GABA-B receptors. In that sense, it's slightly different from baclofen. Indirectly, it has effects on the dopamine, glutamate, serotonin, and endogenous opiate system. It has a short half-life, relatively short. It is safe in patients with severe liver failure and in patients with severe renal impairment, and so you can compare it with disulfiram. There's a completely different mechanism of action, of course. The PK is, the half-life is variable. Of course, we don't use it in people with severe liver disease. Probably we can use it in people with severe renal impairment. And naltrexone, it's a little bit more contraindications, although I would be careful with the dosage that we use. This is not that important. Camprosate, at least it has an effect on the glutamatergic GABA balance. I think the exact mechanism of action is still not known, although some naughty persons have said it's basically the fact that there is a lot of calcium in the medication. And finally, there's Baclofène, and you heard everything about Baclofène just a few minutes ago. So there is a medical need, and maybe sodium oxybate can fill this medical need. It has a wider mechanism of action, and it's more closely related to alcohol than many of the other medication. It is already approved treatment in countries like Italy and Austria. In Italy, it was approved for withdrawal and maintenance of abstinence, but right now it's mainly approved for alcohol withdrawal. Although I think that doctors are still using it because they have a lot of experience with it and don't want to give it up. There is an international clinical development research project conducting to expand this possibility to prescribe sodium oxybate, and I will talk mainly about 2 phase 3 randomized controlled trials in alcohol withdrawal syndrome and 1 phase 3 trial to confirm the efficacy that was established in smaller previous trials. Recently, this work has been presented in a PhD thesis where I was the thesis advisor, and if you scan it quickly, then you can actually obtain the thesis. So what about the efficacy of sodium oxybate in an alcohol withdrawal? There was some early evidence of the efficacy of sodium oxybate in alcohol withdrawal syndrome. These were 3 studies, and you see the ends are being mentioned here. They're relatively small studies comparing sodium oxybate either with placebo or diazepam in different dosages. And basically, either sodium oxybate in these early studies was superior to diazepam, or it was not significantly different in terms of reduction of withdrawal symptoms compared to diazepam. So there are now new studies, 2 new studies, and the first is the GATE-1 study. It's an equivalence trial, phase 3 trial, double-blind. Here you see the numbers in the study, 127, equally divided between the 2 arms. 10 days treatment plus 10 days untreated follow-up in 4 EU countries. These are the dosages that you see. Inclusion criteria, adult alcohol-dependent patients with a SIVA score of more than 20, so serious withdrawal, and no history of seizures. Endpoints were relative change from baseline to day 10 in the SIVA scores, and secondary was a total score of the SIVA. The equivalence margin was taken as 30% relative change from baseline to day 10. So this is the findings, and it's quite easy what you can see. No difference means 0 difference, and so the line is completely on this 0. So there is equivalence between sodium oxybate and oxazepam at all time points in this study, in the ITT analysis. And you see that there is a slight difference, but this difference is not clinically relevant. Equivalence was also observed in the per protocol and estimate analysis. So this is a quite straightforward outcome. No difference between oxazepam and sodium oxybate. This is shown in a different way. You can see it very quickly, and this really looks like no difference, isn't it? There was also no rebound detected during the 10-day untreated follow-up. The second study was a study, again, an equivalence phase 3 trial, double-blind, slightly smaller, almost 100 patients, divided in 3 groups. Sodium oxybate 50 milligrams per kilogram, sodium oxybate 100 milligrams per kilogram, and clomethiazole 1,000 milligrams per day. 6 days active treatment instead of the 10 days in the previous study, and 2 days placebo treatment. Was conducted in one country only, it was Austria. You see the same inclusion criteria, endpoints were very similar, but at different moments, day 6 and day 8. And you see there was also an equivalent margin of very similar 1.5 points on the cyber scale. This is the outcome. What you can see is the line there is the equivalence, and you see there was equivalence between SMO 100 milligrams. Let me see if I can show it here. It's the SMO 100 milligram with the reference, which is the clomethiazole, and there was non-inferiority between the 50 milligram, like it is. This difference is under the inferiority. So the protocol population from both the 50 and the 100 milligrams was equivalent to clomethiazole, and if you want to see it again, this is really showing very, very similar results. And again, there was no rebound detecting during the 2-day placebo-treated follow-up of days 7 and 8. So much for the sodium oxybate in alcohol withdrawal, basically showing that sodium oxybate in 50, but definitely in the 100 milligrams per kilogram is equivalent with, seems to be equivalent with both benzodiazepines and clomethiazole. What about the efficacy of sodium oxybate in the maintenance of abstinence? These were the early studies. Most of the time they were relatively small studies. You see sample size ranging between 17 and 82 patients. Most of the time there were 2 times to compare it. There was a placebo. In 2 studies there was the placebo was naltrexone, in 1 study it was naltrexone and disulfiram. And what you basically see in all these studies that there was a significant better outcome in different alcohol outcomes for the sodium oxybate compared to not only placebo, but also compared to naltrexone. You see abstinence rate is 31% higher in the sodium oxybate compared to the naltrexone medication. And here you see the same thing on basically here on the craving scale. It's significantly better than naltrexone, and it's significantly better than disulfiram in this study. Here it is only on the craving scale, and you see again it's significantly better on, than placebo on the craving. Now these were small studies. There were randomized controlled trials, but with limitations. And so this is the first phase 3 study recently published, and the question was, does a phase 3 study really confirm the previous finding of sodium oxybate in the efficacy of maintenance of abstinence, and important also, does it, the effect, is it sustained after we stop the treatment with sodium oxybate? This was the methods. It was a 3 double-blinded study, randomized 314 patients, 2 parallel groups, sodium oxybate 50 milligram per kilogram per day, or an identical placebo. Psychosocial support for all patients, multi-country study, 11 sites, outpatient treatment, all of them. Main inclusion criteria, it's adult alcohol dependence with a certain period of abstinence before randomization, which is important, as we heard from Roberta. Main exclusion criteria, it's all quite clear. This is the design of the study. 20 days between screening and randomization, then 6 months treatment with either sodium oxybate or placebo, then a 6 months medication-free follow-up period, and these were the primary and secondary endpoints: cumulative abstinence duration over 6 months period, meaning that primary effect was designed at this moment. And of course, we want also sustained abstinence, and that was the abstinence rate at both 6, but also at 12 months after baseline. We also looked at time to first relapse, and of course, we looked at craving in the study. These were the main findings. The main findings were that in the pre-specified analysis at 6 months, it turned out that the adjusted mean difference in cumulative abstinence duration was 43 days over a period of 180 days, which is not only significant but also, I think, clinically relevant and substantially. We did some sensitivity analysis in different ways. I'm not going to in details, but whatever we did, we came around the 30 to 40 extra abstinence days, which you can see in this slide. This is at 6 months, and this is at 12 months. And so it seems that you don't even have only have an effect, a significant and relevant effect at 6 months treatment, but also after a treatment-free period of 6 months, you still have actually an increased effect size at 12 months. This is what you see here. It was a difference of 82 days over a period of 360 days. So we also did look at some meta-regression analysis to see whether there are predictors of these kind of effects, and especially whether it makes a difference whether you have a severe population or a non-severe population, and the treatment duration. This was published this year in Alcohol and Alcoholism. This was the selection. Actually, we included 7 randomized controlled trials with a total of about 1,000 patients. We defined severity in a way that was done before in studies with other medications. And so this was the network meta-analysis plot. So you see most comparisons are between sodium oxybate and placebo. There was also some studies between sodium oxybate and naltrexone, and much fewer study with actually only one with disulfiram and sodium oxybate plus naltrexone. From this network meta-analysis, it became very clear actually that population severity has an important effect. You see here in population severity has a relative risk of 3.1, very significant. So the more severe the population, the larger is the effect size of sodium oxybate. And treatment duration, you see there is actually no significant effect in terms of abstinence rate. If you look up at the percent days abstinence, it looks slightly different. Population severity still is an important predictor of outcome of sodium oxybate. And treatment duration here seems to have also an effect in which that every month longer treatment results in 11% extra month of treatment. So altogether, there is an indication that both severity and duration of treatment might have an influence on the effect size of sodium oxybate. Oh, okay, I'll skip this one. So this is the conclusion with regard to the efficacy, high severity population, longer treatment duration associated with larger SMO treatment effect size. That is definitely clinical relevant benefits for high severity populations in 3-month treatments. You also see clinical relevant benefits in mild severity population, but only with the 6 months treatment. So it seems that in that population you need to treat longer in order to get the outcomes. Results are based on the 7 RCTs. There seems to be a low risk of bias or some concerns for all domains except for the risk of bias due to missing outcome data for 5 studies and a risk of bias in measurement of the outcome for 4 studies. So this is what we know from the efficacy of maintenance of abstinence. And of course there are questions about, because it looks like alcohol a little bit, so there could be safety issues. This is a study that, this is some comparison. It's not only treated, not only used for the treatment of alcohol dependence, but also for the treatment of narcolepsy. And you see doses are in the treatment of alcohol dependence a little lower than in the treatment of narcolepsy. And so for alcohol dependence, it's only approved in 2 countries, and you see for narcolepsy, it's approved in both the United States and the European Union. And so it's the question whether sodium oxybate in this new population, not the people with narcolepsy, whether it's safe. And I would like to refer to a systematic review that was published recently by Giovanni Addolerato and his colleagues, looking both at safety observations in clinical trials and in large post-marketing data sets. So the comprehensive data set that we had was about 3,000 patients in all kinds of clinical studies, 46 clinical trials, and about 300,000 patients treated in post-marketing studies in Italy and Austria. And basically in both these kind of data sets, there were no safety concerns reported. Most frequent adverse events were dizziness, vertigo, headache. No deaths were reported to sodium oxybate, neither in the post-marketing nor in the clinical trials. There were 6 serious adverse events related to SMO in clinical trials. These are the adverse event meant toxicity to various agents, epilepsy, loss of consciousness, discomfort, overdose, and intentional overdose. None of them led to fatalities. There was a similar incidence of serious adverse events in SMO and in the placebo groups, and no side effects due to the combination of alcohol and sodium oxybate, which is remarkable, but still it's a repeated finding. So there is, of course, special characteristics and side effects that you want to look at. These are the ones: abuse and misuse, dependence, overdoses, and diversion or criminal use of sodium oxybate. Sodium oxybate for some time was known as a rape drug. I think there is now quite some reviews, and I think even the French agency recently concluded that this was not the case. This doesn't come out in this review either. You see there's no diversion or criminal use. You see there is some abuse and misuse in certain population, maybe mainly in polydrug addicts and in severe psychiatric comorbidities. For the rest, there is actually very little indication of abuse and misuse, and that is even more the case in dependence and withdrawal. Very low levels of that kind of complications, and the same is true for overdose, where you see very low numbers. This is the post-marketing data, so you see it's 300,000, and yeah, these numbers are, I would say, negligible. Now, these are post-marketing data. They're not perfect. They're an indication more than hard evidence, but it is, the numbers are by now negligible. I'll follow slow. Let's see. Yeah, I have to slow. So there is low risk of abuse and dependence in the current posology. Dependence to illicit GOP is reported in humans. Recreational use of GHB. It was quite prevalent in the UK, in the Netherlands. It's going down now, but There is this risk, but you have to realize that dosages that are used in recreational use are much higher than the ones that we prescribe here. There is GHB withdrawal syndrome is reported, but only in very high dosages, as you can see here, where people use very high dosage and in intervals of 45 to 2.5 hours that they take another dose of GHB. If there is GHB withdrawal, nowadays, most of the time we treat it not with benzodiazepine, but a tapering dose of pharmacological sodium oxybate. So, conclusions with regard to the alcohol withdrawal syndrome. SMO efficacy is for alcohol withdrawal syndrome is supported by positive results from 2 phase 3 studies and a series of small pilot randomized controlled trials. SMO is definitely more important than placebo with a large effect size, and it seems to be similar in terms of benzodiazepines and clometiazole. Maintenance of abstinence, phase 3 trial, large double-blind trial, shows maintenance of abstinence not only during the treatment but even after 6 months of treatment-free follow-up. Better outcomes in high severity population and longer treatment duration with larger effect sizes in these populations, and tolerability and safety seems so far no serious safety issues involved with the posology that is generally used. So thank you very much for your attention. Again, one question. If not, then we move on to the third presentation, and it's Julien GUIRAUD from Paris. He just finished his thesis, and recently he started to be interested in thinking about whether there is substitution treatment for alcohol dependence like it is for other substances of abuse. And he had some conceptual issues on that topic, and he was also looking at potential candidates. So, Julien, the floor is yours.
Thank you, Wim. To be here. So I'm going to present you some data regarding substitution treatment for alcohol dependence. But first of all, my declaration of interest, not so many. And what I'm going to present you will be published in a book chapter, which is going to be released in the next weeks or month, in the International Review of Neurobiology, number 175. So if you are interested in this topic, we invite you to read the chapter once released. But first of all, is there a need for substitution therapies for alcohol dependence? So we will try to answer this first question. And for that, we will have an overview on the need and the efficacy of existing intervention for the treatment of alcohol dependence. So what do we have? We have psychosocial support, and there is a recent meta-regression analysis which has investigated the response in patients treated with psychosocial intervention, and results show that patients treated with psychosocial support have a success rate of between 10 and 30% in maintaining abstinence after 6 months of treatment. So, unfortunately, many patients fail to maintain abstinence with psychosocial support, but we have several pharmacotherapies to improve the success rate, and let's have a view on the efficacy of this intervention in the maintenance of abstinence. There have been a large network meta-analysis conducted by Cheng and researcher, which has been published in 2020 in the BMG, and which show that among approved pharmacotherapies for the treatment of alcohol dependence, only acamprosate show benefit in the maintenance of abstinence with a rather modest effect size. So even with pharmacotherapies, a large proportion of patients, unfortunately, fail to maintain abstinence. But there is not only the maintenance of abstinence, there is also reduction of alcohol consumption. And there is one drug in Europe which has been approved for the reduction of alcohol consumption, which is nalmefene. And nalmefene has shown a beneficial effect in the reduction of alcohol consumption, but again, with a rather modest effect size. So overall, existing interventions have shown efficacy, but there is still a medical need. But is there a need to introduce substitution therapies for alcohol dependence? You know, substitution therapies for alcohol dependence can be somehow seen as the replacement of alcohol by another psychoactive substance which is less harmful than alcohol. So let's have a view whether we can find many substances or whether there are only a few substances which are less harmful than alcohol. And for that, there have been a work conducted by Van Amsterdam and also Professor Van den Brink, analyzing the harms of different psychoactive substances, and the results show that alcohol is the most harmful addictive substance in the EU, and by a large proportion. So there is clearly a room to find psychoactive substances which may substitute for alcohol. And this was basically a little bit the topic of this, of this chapter. So can substitution therapies for alcohol dependence fulfill, at least in part, the medical need? If they are at least as effective as substitution therapy for the treatment of opiate and nicotine dependence, it will clearly be the case. And there are several questions which remain open for substitution therapies for alcohol dependence. How could we define them? Which drug may be potential substitution therapies? And are they safe and effective? So we will try to address those questions in the next slides. And first of all, what is the definition for substitution treatment for alcohol dependence? And for that, criteria have been proposed by both the WHO as well as by Jonathan Chick and David Nutt. And those criteria can be organized in 4 categories. The first category is being the mechanism of action of substitution therapy for alcohol dependence. And the criteria are that substitution therapy should be a psychoactive substance, pharmacologically related to alcohol. It should bind alcohol receptor or substitute for alcohol. And ideally, it should have a longer duration of action than alcohol to prevent the emergence of alcohol withdrawal syndrome. In terms of efficacy, it should be effective in the prevention or in the treatment of alcohol withdrawal syndrome, in the reduction of alcohol consumption or in the maintenance of abstinence, and in the craving as well. For the safety, the criteria are that the substitution drug should be less harmful than alcohol, but we have seen that it's easy. This criteria is easy to fulfill. The substitution drug misuse should be less than that of alcohol, and that it should be safer in overdose than alcohol, not to be used along with alcohol, and ideally not potentiate the effect of alcohol. And finally, it should provide significant health benefits. So these are basically the criteria that we can find in the literature regarding substitution therapies for alcohol dependence. And now, since we have those criteria, let's see whether we can find some compounds which may fulfill these criteria. And the first criteria are related to the mechanism of action, and we can see that it should be related to alcohol. So let's have a view on the mechanism of action of alcohol. And there is no alcohol-specific receptor in the brain. Alcohol is a small molecule, and this molecule binds to what we call ethanol-sensitive binding sites, and several ethanol-sensitive binding sites have been identified. I have not presented all of them in this slide because there are so many, but I have made only a summary, and one of them is the NMDA receptor. Alcohol is an antagonist to the NMDA receptor, and the action of alcohol on this receptor results in a decrease of glutamate with a CNS depressant effect, and a prolonged exposure will result in an upregulation of the NMDA receptor, which causes withdrawal symptoms, stress, impulsivity, craving, and relapse when alcohol is stopped. There is another group of ethanol-sensitive binding sites which affect the GABA system, which are the glycine receptor, the GABA-A receptor, and the L-type calcium channel. And alcohol, for instance, is a GABA-A agonist, and it results in sedative effect and the reduction of anxiety. And the action of alcohol on the GABA system also results in an indirect effect on the dopamine, with a dopamine release leading to a reward effect. And there is another target of alcohol, which is the nicotine acetylcholine receptor, which results in an increase of dopamine as well. And we can find also the 5-HT receptor, 5-HT1, A, B, and 3 receptors. And alcohol act on this receptor with, in terms of consequence, a dysregulation of the serotonin and a decrease of serotonin level with prolonged exposure. So now we have a better view on how alcohol is acting in the brain. Let's see potential substitution therapies for alcohol dependence. So I've mentioned that alcohol is an antagonist to an NMDA receptor, and therefore NMDA receptor antagonists such as ketamine or memantine may qualify as substitution therapy for alcohol dependence, since we can say that they are pharmacologically related to alcohol. The same for GABA-A receptor agonists such as sodium oxybate and benzodiazepine. The same for varenicline, which is nicotine acetylcholine receptor agonist. And here I have presented some agonists to the 5-HT1A, B, and 5-HT3 receptors. So all of them might be potential substitution therapies for alcohol dependence, since we can say that they are pharmacologically related to alcohol. I will not present clinical data and so on and so forth for each of them, because the presentation will be by far too long. We have analyzed each of them in the book chapter, and the result is that sodium oxybate is probably the closest to a substitution therapy for alcohol dependence, and therefore I will focus on this one in the next slide. And just to remind a little bit the criteria, so it should be pharmacologically related to alcohol, it should substitute for alcohol and have a longer duration of action than alcohol. And sodium oxybate is a GABA-A agonist, and therefore it is pharmacologically related to alcohol. As alcohol, it reduces the glutamate level, reduces serotonin levels, and increase dopamine level in the brain, so it shares a lot of similarity with alcohol in terms of mechanism of action. And whether it's substitute for alcohol, to answer this question, we can have a look on discrimination studies. And in discrimination study, sodium oxybate fully substituted for alcohol and vice versa. So this criteria also is fulfilled for sodium oxybate. And the third criteria regarding the duration of action, sodium oxybate has a quite short half-life. However, when it is administered 3 times a day, it has shown efficacy in the treatment of alcohol withdrawal syndrome. So it is unclear whether this criteria is fulfilled, but there is no issue in the treatment of alcohol withdrawal syndrome. So moving very quickly to the efficacy result, Wim already presented the efficacy, and sodium oxybate have shown efficacy in the treatment of alcohol withdrawal syndrome, and also in the maintenance of abstinence, especially in the high severity population. We can present that sodium oxybate have also shown evidence of efficacy in craving in multiple studies, including the phase 3 study. So the criteria regarding efficacy appear to be fulfilled as well. And regarding the safety, again, Wim has presented the data previously, and there have been no safety concern based on the comprehensive database. Cases of misuse, abuse, overdose were rare, both in pharmacovigilance and in clinical trials. And there have been 3 interaction studies which were published, investigating any potential interaction between alcohol and sodium oxybate, and the 3 did not identify any interaction between alcohol and sodium oxybate, despite the use of quite important doses of alcohol, almost 50 grams per 70 kilo of body weight in single intake. So quite important dose of alcohol. And regarding the health benefits, sodium oxybate have shown a risk ratio in the abstinence rate of almost 3 in the severe population, which in fact reflect a number needed to treat of 5, which is good. And to illustrate a little bit what this could represent, we can use the data from Ferling and colleagues published in 1994. In this study, they estimated the mortality rate in the patient population successfully treated for maintenance of abstinence, and in a patient population who failed to maintain abstinence. And using those data and applying the efficacy result of sodium oxybate has the potential to reduce by 30% the preventable mortality, which is clinically relevant. So overall, when we look at the criteria for substitution therapy, sodium oxybate appear to fulfill them, almost all of them. Maybe the duration of action is unclear, but for the other, there are evidence supporting the fulfillment of the criteria. And I will just talk a little bit regarding baclofen. Baclofen has been reported as a substitution therapy for alcohol dependence in several papers. So let's have a view whether it fulfilled the criteria which has been reported in the literature. And if we have a look on the mechanism of action, baclofen is a GABA-B receptor agonist. And after a quite extensive search, I have not found that GABA-B receptor is an ethanol-sensitive binding site. So it is unclear whether we can consider that baclofen action is pharmacologically related to alcohol. So this criteria is unclear whether it's fulfilled. And regarding the criteria whether or not baclofen substitute for alcohol, in a discrimination study, baclofen failed to substitute for alcohol. So this criteria does not seem to be fulfilled either. And regarding baclofen efficacy in the treatment of alcohol withdrawal syndrome, as presented by Roberta before, no conclusion can be drawn currently, and there is a need for updating the Cochrane meta-analysis. And for the maintenance of abstinence, results were mixed, but results from the recent Cochrane meta-analysis show a positive effect of baclofen in the maintenance of abstinence. So this criteria seems to be fulfilled, but there is a need to identify baclofen effect modifiers. And regarding baclofen safety, low doses of baclofen appears to be well tolerated. However, some concern have been raised with higher doses, with higher incidence in one phase 3 trial, higher incidence of serious adverse event. And there have been also observational studies conducted in France showing some safety concern with the use of high doses of baclofen. So whether baclofen is a substitution therapy for alcohol dependence is still unclear because results are mixed. Several criteria does not seem to be fulfilled. And then I will shortly discuss managed alcohol program. So what are my managed alcohol programs? Managed alcohol programs provide health services and manage alcohol consumption to homeless people with severe alcohol dependence. This patient population is very difficult to treat because some of them fail to respond to existing interventions, some of them don't want to be treated, so it's a very complicated patient population. And this managed alcohol program have been implemented first in the late 90s, essentially in Canada, in the harm reduction model. And the efficacy of those programs have been investigated in 3 control studies, which are not randomized, so the quality of evidence is rather low. But in each of these 3 studies, benefit have been shown in terms of participants treated with in managed alcohol programs. With those programs were associated with fewer hospital admission, fewer alcohol-related harms, fewer detox episodes, and lower alcohol consumption as well. However, it seems to have this program seems to be quite heterogeneous in terms of policy, and the heterogeneity in terms of policy affect the effectiveness of this program on alcohol-related outcomes. Nevertheless, it seems to be quite a promising approach for this very, very severe population. So, to conclude, here is my conclusion. Substitution therapies for the treatment of alcohol dependence may at least in part fulfill the medical need. Among the potential substitution therapies for the treatment of alcohol dependence, sodium oxybate appears to be the treatment which is the closest to a substitution drug for alcohol. It is already approved and used for more than 3 decades in this indication in 2 European countries with no safety concern. For Baclofène, results are mixed, even though it has been reported in the literature as substitution therapy. And for managed alcohol program, it seems to be a promising intervention for very severe and harmless alcohol-dependent subject. And we argue that better alcohol-dependent treatment can be provided if substitution therapies are implemented at a similar scale as for opioid and nicotine dependence. Thank you.
Okay, I see a question. I see 2 questions.
Thank you for your presentation. I have a question for you and also for the 2 other speakers. I think you could add in modification related to alcohol, opioid system, but also cannabinergic system, because we know from the work with the no-Ravolkov, there is decrease from 20 to 25% of CB1 receptors for several weeks in alcohol-dependent patients. So big mess in the brain. I'm not sure it is not alcohol substitution based on the discrimination study you mentioned in 1994. It was from rats, isn't it? They were alcohol dependent or not? Yes, but what was the dosage of Baclofène? And we know that dosage is very important, and you mentioned the importance of the anxiety. And when you discuss with the patient with the severe alcohol disorders, when they have anxiety and behind the craving there are some uncomfortable sensations such as anxiety, they need to drink. And when you increase progressively Baclofène, the patient said, well, it's providing me the same comfort, less intense than alcohol, but it helps me to manage my craving, and then I decrease to drink. So you see, you cannot conclude so hardly regarding Baclofène, because we know that according to individualized treatment, you can provide the correct dosage at the correct time, because craving is fluctuating during the day, and we know that the key with Baclofène is personalized treatment. And what is the correspondence? Because it's very interesting. Oxybate is a kind of mixture of Baclofène plus benzodiazepine. So it's very interesting. What is the correspondence in terms of dosage? Because when the patients are under Baclofène and you put just a little of benzos, poof, you amplify the effect. So it's very important to have some concordance, equivalence between the 2 medications. Thank you for all of you.
Thank you, Maurice. No, you're definitely right. Based on current data, indeed, some criteria are not fulfilled. That doesn't mean that if we bring new data, the criteria may be fulfilled. So you're definitely right. And regarding the similarity between Baclofène, benzodiazepine, and sodium oxybate is a precursor of the GABA. And for Baclofène, yeah, it's less clear. And sodium oxybate, in fact, is a sodium salt of GHB, which is also an endogenous substance, which may explain also the safety profile, why it's well tolerated. And when we look more closely, you're definitely right. There is also a component in terms of action of alcohol on the opioid system. The same is true for sodium oxybate as well. I did not mention it to not put too much information in the slide, but you're definitely right. and why we have such difference in terms of efficacy profile and mechanism of action, that's an open question. Yeah, with patient. And the fun thing is that combination therapies have been also studied. And when you combine, for instance, sodium oxybate with naltrexone, you increase success rate in controlled trials. And it seems to be true also for varenicline, for several compounds. So maybe since their action is not fully, completely related to alcohol, if you compensate with another substance which will act on another system which is affected by alcohol, you may increase the efficacy. So
it's very likely in some other fields of medicine that we start actually with combination treatment, and only when you see success, then you start to taper down, and it's a very interesting way to do it. Sorry, we can't do it. Okay. Okay. The only thing is, when do you start it? Do you, if everything fails, or do you start really from the beginning? Because we know as long as people are drinking, there's damage. And so I think people in rheumatology, they start with combination therapies because they don't want people to get more damage while we're trying 8 different medications one by one. So I think it's a very interesting question, combination therapy. So thank you very much, Julien. So we move to the fourth presentation, and it's still on alcohol. We're moving a little bit away from it, but it's adding some additional intervention, e-health on other interventions. So I think it's very interesting that Géraldine TALBOT from Montreuil is going to talk about integrating e-health into the care process of patients with alcohol use disorder.
Thank you very much for being so courageous as to stay with us on the Friday afternoon. And I'm going to present to you the integration of e-health in the healthcare process in alcoholology. Experimentation for Oz Ensemble and direct the association Capacité, which is based in the Paris region in Montreuil. I don't have any conflict of interests. To show you, give you the context, my colleagues have asked the question about are there any disorders in terms of screen use. We're still working on this. In any case, the rate of digital coverage is very high in France, because 80% of adults today have access to digital devices, and this access may be problematic for some people, but it is also a resource. So why not turn this into a resource for healthcare? Here, in terms of figures, to give you some an idea. Alcohol is a major public health issue today, because 5 million people in France suffer from alcohol-related disorders. And that represents 120 billion euros in terms of the social cost of alcohol in France each year. And it is the second cause of premature death, avoidable death in France. If addictology is a speciality, in terms of number of professionals, it's the second cause of premature death in France, and I think by making it more well known, we would this would be good. We mentioned in the public health study in France, it was said that only 5% of patients who suffer from addictions benefit from suitable, adequate care. And when this occurs, it happens usually with a delay of up to 10 years. And this study also highlighted the fact that the situation is not evolving and hasn't done so for the last decade or so. As a clinician in addictology, I can see that people who arrive at my practice very often there was already consumption, and they had 2 or 3 extra glasses per day in the beginning, and then this continued to increase. And if some kind of life event occurred, then this could trigger even more. However, the centre I worked in Montreuil, we work very often with this type of 45, 50-year-old users, and the entire family and is affected. So we try to think with health professionals in the field of addictology and in the field of professionals, and to try to provide focus groups for older users and try to determine with them, because they were already being followed in addictology, what would be one of the breaks on care for them. And here are the 4 main things that they said in these groups. Firstly, initially it's difficult to become aware, and this happens at a very late stage. Very frequently, the consumption of tobacco and illicit products was quite easy to identify. Do you consume these substances? Yes. But for alcohol, the notion of threshold is very difficult for the public in general to understand. And it also mentioned, they mentioned the search for independence in their initial attempt to control the situation. We know that in addictology, the problem of controlling disorder is a sign of an addiction. What they meant by this was when they started to have negative effects due to their consumption, they very often, in terms of professionals, they were labelled. And so the doctor would say, you're an alcoholic and you've increased your consumption, but without them really being in charge of the situation and what was being described by the health professional. For example, when the blood pressure, if they can see for themselves that their blood pressure is high even at home, they weren't supported enough in this disorder, and also they wanted to be supported independently, but with a professional who provides the correct advice. They often didn't feel that they were being advised appropriately by professionals. They also said that the waiting times for the initial care, and that's something that we observed ourselves as health professionals. If we could propose an appointment 2 or 3 weeks afterwards, that would be great, but we've often talked about self-medication over the last few days. So between something which is kind of a life ring, this is something they could actually use. And then finally, they said about the bureaucracy of the support programs, that often people who have a precarious situation in terms of employment or their life, and so to enable them to, we need to be able to, in order to get them to several consultations per week with very often long transport times, rather than doing it close to their place of work or their home, means that these programs, which may seem adapted and suitable to us, are not in fact suitable for them. And the risk of alcohol in general, we wanted to facilitate access to risk populations or people with dependency with a pluriprofessional approach with digital resources. So we wanted to favour access to multidisciplinary digital care for alcohol to help them identify and coordinate, to help the different people involved to coordinate work better, to make distance or remote care possible, and those people with psychological and social issues take part, and the relevance of this type of care in a context of developing e-health in France. The system was initiated, was a response to the Paris region health call for tender. It's a state startup, is a digital public service developed by a dedicated and autonomous team, both in terms of care and the digital system that is being used, which solves a public policy problem with an incremental approach. This state startup works in collaboration with the Fabrique du Numérique, which belongs to the social ministries, which provides the technical means for this application. And it's an incubator in order to develop a public service. So here we were trying to tap into healthcare professionals who could be mobilized, focus groups, and even the users who we met. It's financed by the Regional Health Agency for the Paris region, and also by Mildeca, which is the interministerial mission for fighting against drugs and addictions. To present the health care pathway, it's a healthcare pathway, not just an application. Later I will present this in more detail. But to give you an overview, it's a digital application which can be downloaded free of charge from the App Store, and which it encourages increased awareness, then an initial contact unit with appointments will try to obtain a commitment. Then we have a tele-intervention unit, which is multidisciplinary, digital, and which will carry out the diagnosis of the situation. Then we have the Oz Ensemble digital tele follow-up unit to follow up people. So this is to help people who are have addictions, and then we have the end of the pathway when people get to the end of the process. To show more in detail now the pathways that I presented, first the way to access it. The application can be downloaded by the person themselves independently, because it's available both on Google Play and the App Store. It's free of charge, it's anonymous, and without any account needing to be created. Or a professional may advise the person to pay the subject to download it. For example, the prison services, that would be a good example of that. The application includes the possibility to self-evaluate one's alcohol consumption. The person can position the risk with tests and with tests. The evaluation tool is a tool which is validated for alcohol risks, for healthcare professionals, for psychological support, for social support, and for the users themselves. It's really part of one of the requests by users themselves to have some understandable and reliable information that is easily accessible. The possibility to fix an objective. The application encourages the user to set a weekly objective in terms of alcohol units and the number of days of consumption not to be exceeded. these are standards which are provided by the French health authorities, for example. However, we also use the principle of risk reduction. It's not just simply, we don't want to simply block the user. It's not trying to get down to the recommended daily intake, because this could be too restrictive in terms so they can freely parameterize these aims themselves. The application also has a diary where you can follow up your alcohol consumption in real time by adding daily the alcohol units consumed and the possibility of following up one's objective and evaluating it over time. The application provides a graduated program, a tapered program, based on work that has been which has been published. To give you some illustrations in terms of the tapered or graduated program, in terms of self-evaluation, we have activities. The first week, the user will be encouraged to reduce their consumption. The second week, they try to identify risk situations, so the user can also parameterize this. They can select the risk situation which seems the least problematic to begin with, and to try their perception with regard to what they could do differently. Every day they'll be given advice, they'll be given feedback, and they'll be able to at the end of the week see if they were able to refuse alcohol more easily, and also their self-esteem. The third week, the person will think about the role of alcohol in their daily life with a quantitative and qualitative evaluation. The fourth week, they look back at their aim and see if they can use or get closer to recommended levels. The fourth week, they have look at their results, and then we can react to this. It provides permanent access to advice, which I co-write with teams of nurses and carers. So if anyone would like to provide an article to enrich our database, then these would be very welcome indeed. We visit the users regularly via the social networks to see what they like to receive and to try to continue feeding the database. And finally, it provides the ability for users, when they feel ready and they're motivated to do so, to exchange with a professional who's been trained in addictology via the Doctor.Lib platform, which is this is the advantage of this. It reassures users because they already know it. They know you don't have to have an account, and we try to. You can see the mention that we're financed by the public authorities, and this reassures them that we are a public state service dedicated for their healthcare. You can organize an appointment within 48 hours using Doctor.Lib. And our teams are available from Monday to Friday from 9 to 6 p.m. The initial contact unit works by an interview, that lasts 30 minutes, which is carried out within the first 48 hours by a mediator in health trained in alcoology. They work on our premises. They have been trained by us, but it's dedicated to this project. It's generally based on the validated RPIB technique. The objectives of this interview are to increase awareness of alcohol, the risk of alcohol, and to try to match up the data entered using the self-questionnaires and the person's experience to answer any questions they may have, and to look at other products and addictions. Although the initial application is dedicated to alcohol, one of the requests by users were to have some kind of platform. They prefer. They don't want too many questions about other products in the beginning. This person asking the question didn't have a microphone. It's somebody who's trained in addictology and whose vocation is not only to look at the social aspect of things. According to the information provided, you have this graded score and the level of support that's required, which could go from sending a brochure by mail to actually meeting them seeing them in person, when 30 minutes is not enough. This diagnosis of the situation is an in-depth evaluation for harmful consumption, dependence, and complex situations. It has a psychological interview, last 1 hour, and medical animals, which lasts 1 hour, and a socio-health interview, which lasts 1 hour, and then we see their eligibility and their motivation. If the person wishes so, they can then receive a remote follow-up for their harmful consumption dependence, and with their motivation to reduce their consumption, and we could then, if necessary, send them into the physical health system, or when there's no referring GP, or because the appointments, it's too difficult to get an appointment, or because the person refuses the use in person, or because their addiction stops them from driving. There's a lot of compliance with healthcare, psychiatric and somatic comorbidities, which makes going to an addiction site very difficult. We can propose a follow-up that lasts 6 months, which takes place remotely. In terms of the main results between 2021 and 2023, the number of downloads every year has gone up to 15,000, with 3,000 daily connections, 600 patients in terms of the tele follow-up, the remote follow-up. In terms of demographics, the most highly represented age group is the young and female, and populations which are perhaps not followed in the traditional system. And of course, the main question is, does it actually work? We carried out an analysis of alcohol consumed per day whilst the application is being used, and we analysed the 61st users who used the application. This is more than 2,000 measures, and we saw that there was an average reduction over 6 months of around 55%. In terms of the figures, this represents 8 glasses in the beginning, with a reduction in consumption in the first 2 months, and down to about 2.5 glasses at the end after 6 months. So it rarely leads to complete abstinence. Here's some things that have been said on the app stores about it. And by way of a conclusion, I'd like to say that Oz Ensemble is an additional complementary tool for patients in addictology, with the comprehensiveness of the application, the fact that you can have an autonomous follow-up of the patient between different appointments, and it shows motivation and savings made in terms of euros and calories. And it's also very good for patients who can't actually get to centres or who live a long way from centres. And the perspectives for making this long-term and deploying it nationally are good from 2024 onwards. Thank you very much.
One. If not, then we move to the last presentation, and that will be a presentation by Sarah Morisot from Bordeaux, and she's going to present a new initiative, I think, to add something that's really needed, working on recovery.
Merci. Bonjour à tous.
Thank you. I work at the SAMSI laboratory with Marc Auriacombe, and I will talk to you about the VITAE study. It's a pilot study for the evaluation of the impact and viability and transferability of an alcohol harm reduction support program. In France, alcohol is the second cause of cancer that can be avoided after tobacco, and less than 10% of the population has access if alcohol-dependent patients have access to treatment like tobacco. So this can be explained by different factors, by stigmatization of consumptions and addiction, the desire of people to face that alone, or people who drop out, who abandon the treatment because they need to stop drinking when they are hospitalized, for instance. So there are approaches that are necessary, such as harm reduction and the perspective of psychiatric mental health recovery. So there is a program in Marseille. The objective is to cure the person rather than to promote abstinence. It was experimented in 2017 and 18 and deployed in 10 centers in France. These centers were XAPA or CHSS. So a few words about this program. There are 3 steps. First of all, you don't make the person guilty. Then there is a harm reduction part. And finally, the 3rd step is a support towards a care pathway. And this program is done based on, it's customized according to the beneficiary. There is a strong support. There are interviews in the centers, but also home visits and telephone interviews. So the objective of this pilot study is to evaluate the transferability of this harm reduction program to alcohol in 10 centers in France. The purpose was to evaluate the conditions of transferability and viability of IACA in these centers. Is this harm reduction program, can it be transferable in different types of centers who don't have the same type of treatment? And finally, to see whether we could assess the feasibility of a multi-center controlled efficacy study. Concerning the method in this study, we assessed the professionals in the different centers and the beneficiaries. So we wanted to include 10 beneficiaries per center. That's 110. Each beneficiary who participated was enrolled for 12 months, and the inclusion period was 10 months. So the method, first there was a qualitative evaluation of the professionals in the centers and the program beneficiaries. These evaluations took place in the 9th or 12th month after the beginning of the program. There were interviews with the professionals and the beneficiaries. And the second part was a quantitative evaluation only of the beneficiaries. So they were included at the beginning of the harm reduction problem, M0 on the graph, and then there were interviews every 3 months up to 1 year. During these interviews, they had hetero questionnaires. The international psychiatric interview for to assess use disorders, the severity index to assess the severity profile of the addiction. These questionnaires explores different aspects of life that can be affected, then assessment of craving also. Concerning the results, I will tell you only about the quantitative results, the first results. So we included subjects between April 21 and January 22. We included 29 beneficiaries out of the 110 originally anticipated. This is the curve participation during the 12 months of the study. We lost 10 beneficiaries, mostly people who were lost in sight. This shows the inclusion per center. There was no inclusion of beneficiary in four of the centers who participated. Concerning the description of the beneficiaries, most of them were men, average age 43, and studies educational level less than a high school diploma. During the inclusion at M0, we had 10 people were working out of 29. Concerning the living condition, most of the beneficiaries lived alone, 8 lived with friends or family, and finally 4 had unstable living conditions. Concerning the psychiatric comorbidities, we had 17 beneficiaries who had an anxiety disorder, and 2 had other psychiatric disorders. Concerning the use disorder besides alcohol, others had used tobacco and cannabis. The severity of the alcohol use, all of the beneficiaries had a disorder conform in accordance with the MS5, with a severe disorder. The number of drinks per day and the evolution over the study, the average was 17 drinks per day, and this was stable throughout the study. Then the score, the composite score, is a score you obtain with a questionnaire, the AIC questionnaire, to evaluate the severity of alcohol use. It goes from 0 to 1. The closer to 1, the more severe the use. So we can see that there is a decrease over the 12 months of the study. And when we look at the score, when we compare it between baseline and 12 months, 17 beneficiaries that went to the end of the study, 15 improved, 1 stabilized, and 3 deteriorated. Concerning the alcohol treatment, in this study, the beneficiaries participating in the IACA program could also be treated in other centers with other alcohol treatment, and they could also stop the IACA and be in the study. So the two groups show how many subjects were followed by IACA and those who were only had a treatment for alcohol use disorder. Then at every evaluation, the beneficiaries were asked how they needed additional support for alcohol, and there is a decrease of the request for more treatment, which makes sense for those who were in the study. Concerning the empowerment scores, we didn't see any evolution. It was stable throughout the study. This is the evolution of the composite scores evaluated by the AIC questionnaire. They were different. It concerned family relations, the job situation, psychological condition, and it remained stable throughout the 12 months of the study. The qualitative data, there was a strong mobilization of the centers because all the centers were trained, but once they were trained, there was a lack of time among the professionals. They were trained, but they didn't have more time to dedicate to the follow-up of the beneficiaries in the IACA program. And with few users accepted to start the IACA program in these centers because it was more focused on abstinence than on harm reduction. Concerning the limits of the study, we included only 29 subjects out of the 110 beneficiaries, so few subjects. We could only describe them but couldn't have any statistical analysis. We have a few centers who included participants, 4 didn't include any participants. It would have been interesting for all of them to include some because each center is very different in the treatment, in the number of professionals. And it was difficult to distinguish the effects of the IACA program because the beneficiaries could be treated in another centers at the same time. And those who were in the IACA program, there was a great difference between the centers. Some followed their beneficiaries weekly or several times a week, and in other centers it was only monthly. The expected consequences of the study. We identified the conditions of viability of IACA. Is this program transferable to other centers? And if so, if yes, or if it didn't work, why it didn't work? And then we should define guidelines to transfer the program to other centers. And finally, we should be able to validate the feasibility of a randomized clinical trial comparing with another harm reduction program. I would like to thank the SAMSI team. We were in charge of the quantitative part of the analysis and the MERISP team for the qualitative evaluation. Thank you for your attention.
For one question. So, not having the possibility to have really statistical analysis, would you say that this is a promising approach, or would you say, I saw a lot of things that remained stable? What does it mean? Stable is good, or stable is no reduction?
Stable with a score, composite score?
Yeah. But also with empowerment, because we want to see something in empowerment in the recovery, isn't it?
We hope that decrease, but stable it's okay, but we hope that decrease during the study.
Okay.
Vous n'avez pas encore performé l'étude qualitative, mais est-ce que vous
You didn't do the qualitative study, but did you try to understand why there was no change in the patients? Why did you try to have that information? Why there was no change? The problem we had is that the centers were very different in the type of treatment. In some centers, the professionals had no time because this program requires an intense follow-up, a weekly follow-up. And in some centers, sometimes there were contacts once a month or once every 2 months with a beneficiary. So this is why it would have been interesting to have subjects in all centers to understand and compare across centers. This is very important because if we want for the patients to become actors in their treatment, empowerment and coaching is when the motivation is greater so that to help the patient. If you see them only once every 2 months, it cannot work. The problem is that the centers were trained, but they didn't have more time to dedicate to the program. This is why it would be interesting to do it, to retest it in different centers with people who are available to follow them up. In this study, is really the qualitative study is interesting to understand why it didn't work and to be able to improve the situation. Thank you.
Here up till what it is 4:30 now, at the end of the program. I was very happy that so many people came to an alcohol session because the conference is sometimes dominated by drugs, and alcohol is of course a very important addiction. And so thank you very much for being here. If you're going home, have a very good safe trip home, and probably see you within 2 years at this wonderful place. Thank you.